Good evening. Let me thank the organizer for the kind invitation. The topic that I am discussing today is embarking on novel strategies for metastatic bladder cancer, putting chemotherapy on the back burner. Now, when we talk about standard of treatment in metastatic urothelial cancer, the treatment of choice is either a combination of cisplatin with gemcitabine or a dose MVAC. For those patients who are not cisplatin eligible, it is carboplatin that we give. And for those patients who are platinum ineligible, we give either a atezolizumab or a pembrolizumab. Now, recent years has seen the entry of lot of new molecules in the treatment armamentarium. It started with immunotherapy drugs in the second line, and then it came in the first line, and then they got accelerated approval in 2016 and 17. Then came FGFR inhibitor, that is Erdafitinib. Then came antibody-drug conjugate, enfortumab vedotin. 2020 looked at switch maintenance, the most important, avelumab maintenance, Javelin 100 in the treatment, first line treatment post first 4 cycles of cisplatin gemcitabine. And last year saw when another antibody-drug conjugate, that is a secukinumab, govitecan. So when we talk about treatment advances for patients, what is the role of immunotherapy along with platins in the first line? So 3 pivotal studies, IMvigor 130, Keynote 361, and Danube study. Unfortunately, none of these studies showed any significant difference in overall survival when immunotherapy was combined with chemotherapy, that is platinum-based, in the first line. Although if you look into IMvigor 130, there was slight improvement in PFS, but unfortunately no improvement in OS. So the first take-home message is, in a first-line setting along with chemotherapy, IO does not improve median overall survival. Now comes the question, what about sequential approach? So here came the most important study which came last year, Javelin 100 study. So a metastatic urothelial cancer patient who had at least some sort of a response, either a CR, PR, or a complete response for cisplatin-based chemotherapy, were randomized to maintenance immunotherapy, that is avelumab 10 mg per kg IV 2 weekly versus placebo, and the treatment was continued till disease progression or unacceptable toxicity. Now, what was heartening to know was there was a statistical improvement in both progression-free survival and overall survival. Of course, the quantum of benefit was more than 7 months, and this benefit was more if the tumor was PD-L1 expressed. The overall and the PFS benefit was observed irrespective of PD-L1 status or irrespective whether carbo was given or cisplatin was given. And based on these fantastic results, FDA has approved this as a switch maintenance following first-line platinum-based therapy. What about those patients who are cisplatin ineligible? So there were 2 pivotal studies which had shown impressive response. 2 drugs, atezolizumab in IMvigor 210 and Keynote 052. Now, when you look into the response rates, including a CR, these are good numbers in those who are cisplatin ineligible, and a very impressive median overall survival of around 11 to 16 months. So for those patients who are cisplatin ineligible, the drug of choice is a immunotherapy, either a atezo and PEM, and atezo has an added approval in those with a PD-L1 of more than 5% patients also. Now comes the hard fact. 15 to 20% of patients are primary progressive on chemotherapy. So what to do? Do you give a Taxol, or can you think of immunotherapy in the line who has been given platins in the first line and has not taken any switch maintenance therapy? So here comes the role of second line immunotherapy. So Nivo and Ave has also been approved in the setting, but the category 1 or a level 1 evidence in a phase 3 setting is with the drug pembrolizumab based on the impressive result of Keynote 045 study, which showed prolonged OS and a lower rate of adverse events. Now, when you look into the long-term data of pembrolizumab in a second-line setting, around 21 to 22% response rate. But what was heartening was 10% complete response, 11.9% partial response, and a stable disease of 17.4, close to with the disease control rate of close to 40%. Again, an improvement in OS, which was statistically significant, but more importantly, as we see in immunotherapy, a very higher duration of response of close to 2.5 years. More importantly, this safety profile was consistent with the previous study. When we talk about immune-related adverse event, this is something we important and we need to be careful about. All the organs are affected, but the common side effect that we should look for when we give immuno-oncology drugs are diarrhea, transaminitis, pneumonitis, some degree of drug rash, and of course endocrine, including hypothyroidism. When we talk about immune-related side effects, some important tips to remember. Avelumab that we use in the switch maintenance studies can cause some degree of hypersensitivity. So probably in the earlier cycle, we need to pre-medicate with antihistaminic and acetaminophen. We should be careful by monitoring liver parameters, creatinine and thyroid when a patient is on immunotherapy. We need to be careful about side effects including cough and shortness of breath and diarrhea, and careful, and we need to strictly follow or look into guideline when there is a problem. The second most important drug and exciting drug in the treatment armamentarium is a FGFR inhibitor. Now, there comes the role of genomic testing. So all metastatic urothelial or urinary bladder cancer should be screened for FGFR mutation, or in any case, a broad-based NGS sequencing to see for any genomic alteration. For this, we have drugs available for. But the most important alteration is a FGFR, which is a fibroblast growth factor receptor inhibition. Multiple drugs that have been used in the treatment of urothelial cancer, but the most impressive data among all the drugs is with the drug Erdafitinib. Based on the impressive studies, BLC 2001, which was a study which used this drug in FGFR3 and 2 activating mutation and fusion. Remember, mutation fusion after first line, or it could be in the later line, showed a very impressive response. So when you look into this study, a phase 2 study for those in second and beyond line using Erdafitinib, finally at the dose of 8 mg per day with a primary endpoint of overall response rate with the secondary endpoints as we have seen in the diagram. Now these are impressive numbers. Those patients who have been multiply treated, an overall response rate of 40% with a complete response rate of 3%. Now, what was heartening was for the 22 patients who had undergone prior IO therapy also, this response rate was 59%. So a heavily pretreated patient based on this genomic alteration, a very impressive response. Long-term outcome also showed that there is an impressive benefit in terms of PFS, overall survival and duration of response. So a very good drug in this armamentarium. This ESMO showed that probably those patients with a FGFR mutation who are ineligible for cisplatin, this new study, NORTH, which combined Erdafitinib with satralizumab, showed that this overall response rate, you can see 68% when Erdafitinib was combined with satralizumab. So probably this drug has some synergy when used with IO drugs in the first line, a very impressive duration of response of close to 7 months, and more importantly, a very high disease control rate, close to 100%. So probably in future, you will see this drug coming in the earlier line alone or in combination with novel drugs like IO, and we have a lot of exciting data coming by. Now, all good drugs have a bad drug, so we need to be aware about the toxicity of these FGFR inhibitors. Need to be careful about oral heroin as there is a high incidence of stomatitis, some nail and skin toxicity. Of course, we need to be careful and have a very good support care. Two important side effects, which are class effect, is a hyperphosphate. Careful and have a dietitian consultation if there is this. And more importantly, use a non-calcium containing phosphate binder, that is a Sevelimab. The other and a novel toxicity is a ocular toxicity, a central serous retinopathy and a retinal pigment epithelial detachment. So always do an ophthalmic examination monthly for the first 4 months and then 3 months thereafter, and have to be careful about these novel side effects. The third player in this treatment armamentarium, which we have exciting data about, is the antibody-drug conjugate. So two good drugs that has come, Enfortumab vedotin and Sacituzumab govitecan. Of course, if you look into targets, different targets, Enfortumab targets Nectin-4, and the active payload is MMAE, which is a microtubulin inhibitor. Sacituzumab, which we have already discussed previously in breast cancer, epithelial membrane TROP2 antigen on which it targets. The active payload is SM38, like a irinotecan. So probably a sort of a chemotherapy entity only. Now, when we talk about the pivotal studies in EV301, of course, based on the impressive data of EV3201, this was a phase 3 data in those patients who had taken platinum before and had taken a checkpoint inhibitor. When it was randomized against Taxol or vinflunine, the primary endpoint was overall survival. So a phase 3 data, that is a level 1 data. Now, when you look into the response rate, twice the response rate as compared to chemotherapy. More importantly, a statistically significant improvement in PFS, around 38% reduction in the risk of progression. But more importantly, an impressive overall survival of more than 1 year in those in the third line, with a 30% reduction in the risk of death. The side effects also were manageable, with side effects including peripheral neuropathy, some degree of hyperglycemia, but there was no new signal, and this was a statistical significant improvement against standard of care. Now, the second molecule, and the molecule that has gained approval last year, is trastuzumab govitecan, based on cohort 1 for urothelial cancer patients who had taken multiple lines of treatment, including platinum and checkpoint inhibitor, were given trastuzumab in the standard dose of 10 mg per kg day 1 and 8 every 21 days. Now, what was observed was a very impressive reduction in tumor size, an equally impressive response rate of 27%. Please remember, these were more heavily treated fourth or fifth line also, and around 77% had tumor reduction. Now, when we talk about duration of response, impressive 7.2, more importantly, close to 11 months of overall survival. The side effects are in sync with chemotherapy, that is irinotecan based, what we see, neutropenia, diarrhea, and rarely febrile neutropenia. So again, a very impressive drug in the later lines with a very impressive data available now. Now, this is a study which is probably the important study, which is a phase 3 randomized study of trastuzumab govitecan against platinum for those who has progressed on platinum-based chemo and on a checkpoint inhibitor also. So this study is whether this drug, how the drug fares against the standard of care in the third line. What about the novel toxicities of antibody-drug conjugates? So this is also important to remember. We should keep a low level of for peripheral neuropathy. A degree of peripheral neuropathy, if we see, we need to reduce the drug. The second novel side effect of hyperglycemia. So we have to be careful, and we need to check our blood glucose stringently. The third toxicity is rash. Probably a Stevens-Johnson syndrome is something that we need to be worried about. Probably one of the black box warning. When we talk about trastuzumab govitecan, again, two toxicities, neutropenia and diarrhea. So consider for GCSF support if there is neutropenia, and be careful and keep your antidiarrheal drugs, antidiarrheal medication in support care when there is a evidence of diarrhea. Future holds a lot of promise for these antibody-drug conjugates, as well as, so we have a trial which is comparing enfortumab vedotin combined with pembrolizumab, and this is in previously untreated advanced urothelial cancer. So future we'll have a lot of these trials in earlier setting, along with trastuzumab govitecan in earlier lines in those who are cisplatin ineligible. So probably in future we are seeing this molecule coming in the earlier line. So if I have to summarize my talk, probably in future we'll have a lot of novel molecules, that is chemotherapy. We already have an approval of avelumab as a switch maintenance post first line platinum-based chemotherapy. We have an approval of atezolizumab and pembrolizumab regardless of PD-L1 in platinum ineligible patients. And now in this presentation, I have discussed a lot of novel molecules, including FGFR inhibitor, which is Erdafitinib, and drug antibody conjugate, which is enfortumab vedotin and trastuzumab govitecan. This has a level 1 as well, enfortumab, and probably trastuzumab will have a lot of data coming in the future. These represent effective options in metastatic, treated metastatic urothelial cancer, and in future we'll see this drug coming in the earlier lines, probably in the first line alone or in combination with other molecules. I thank you all